Hello, I'm Dr. Michael Warren, Assistant Commissioner with the Division of Family Health and Wellness for the Tennessee Department of Health. Newborn screening is a process that's been around for more than 50 years. Nationally, the first test was developed in 1963 when Dr. Robert Guthrie developed a blood spot test for phenylketonuria, or PKU. We actually started screening for PKU in Tennessee in 1968. And since that time, our newborn screening program has grown to screen for more than 50 different conditions. Many of those are detected by the dried blood spot test. We also test for critical congenital heart disease as well as congenital hearing loss. The various conditions and diseases that we test for in the newborn screening program can have a major impact on a baby's life. One of the major principles of newborn screening is that you want to detect these diseases early so that you can intervene, provide some treatment, or connect the family with care so that you can make a difference in that baby's life. For many of these conditions, that may mean avoiding developmental delays or other medical complications or even death. So it's absolutely important that we test for these diseases early, get an early diagnosis, and connect these families to care. Very early in a newborn's life, typically between 24 and 48 hours, the baby undergoes testing for these various conditions picked up on our newborn screening panel. Many of those conditions are tested for using a dried blood spot specimen. So while they're in the hospital, they undergo a heel prick where we collect a small sample of blood, and from that small sample of blood, we test for many different conditions. The baby is also tested for critical congenital heart disease by using a small oxygen probe that's attached to the baby's hand and foot to be able to test for oxygen levels. And we also test for congenital hearing loss by using a small sensor attached to the baby's ear or to the baby's head to be able to detect whether the baby can hear the emission of certain sounds. So once those tests are performed in the hospital sends a filter paper, which is a special piece of paper, to the state lab, and that filter paper contains the dried blood spot specimen as well as the results from the critical congenital heart disease screening and congenital hearing loss screening. Those information pieces are all sent to the state lab. The blood spots are tested for various metabolic conditions. If any abnormality is found, the state lab notifies the nurses in our follow-up program immediately. These results are very time sensitive, and so those nurses act right away to reach out to the baby's primary care provider and potentially regional genetic centers who will arrange to have those babies seen for confirmatory diagnosis. If the baby has an abnormal newborn screen, the network of regional genetic centers or medical specialists can work with the infant's family, perform additional tests if necessary, and try to identify whether the baby actually has one of the diseases that's detected through our newborn screening program.
Hello, my name is Dr. Yasmin Khan, and I'm one of the pediatric immunologists at Vanderbilt Children's Hospital here in Nashville, Tennessee. In January of 2016, the Tennessee Newborn Screening Program will add severe combined immunodeficiency, or SCID, to the disorder panel. SCID is a genetic disorder that affects 1 in 50,000 to 1 in 100,000 infants. These babies are born with severe defects in their immune system's ability to fight infections. They often look normal at birth, but within the first few months of life will develop serious, often fatal infections due to their inability to fight common childhood bacteria and viruses, like common childhood viral infections. These babies may also have failure to thrive and chronic diarrhea. Babies born with SCID will ultimately die, typically within the first year or two of life, if they are not identified and treated early. Newborn screening for SCID will allow us to identify babies early, before their first serious infection, which greatly improves their chances of a successful treatment.
My name is Christine Dorley, and I'm the Newborn Screening Division Manager for the state of Tennessee. To test for severe combined immunodeficiency, or SCID, also known as bubble boy disease, we will be using a molecular-based assay that detects TREC, or T-cell receptor excision circles. TREC is a product of T-cell maturation. So in healthy infants, they will have multiple TREC counts, whereas infants that have SCID will virtually be undetectable or very low numbers. Since this test detects TREC, it will also detect other T-cell lymphopenias that are a part of primary and secondary immunodeficiency. This test uses dry blood spot specimens that are routinely collected for other tests that we screen. Once specimens are received, we assign an accession number or unique identifier to each specimen card. We take a small amount, approximately 1.5 millimeter cut or punch, and using polymerase chain reaction, or PCR, we're able to look for TREC. PCR multiplies the number of TREC in the blood spot punch to allow for detection of SCID. Normal babies will have multiple TREC copies, and so will be reported out as within normal limits. Infants with low to no TREC copies will require retesting from the same dry blood spot card. We will repunch and retest in duplicate, and then evaluate the 3 results collectively before reporting a final result. Infants that continue to have low to no TREC copies will be reported as outside of normal limits and will require follow-up. One exception is reporting abnormal TREC results on infants born prematurely. Infants born at less than 37 weeks gestation age will have transient T-cell lymphopenia. This usually resolves with age. We ask that you be diligent in recording the infant's gestational age and NICU status on the appropriate areas of the specimen card. This information helps to guide us in reporting in our follow-up process. Please keep in mind that abnormal TREC results on a term infant and abnormal results on the repeat screen from a premature infant will require testing and confirmation. Diagnostic testing is done by flow cytometry and requires a quick turnaround once the provider has been notified of an abnormal screen. Rapid and accurate diagnosis of an infant with SCID is very crucial to their treatment and survival. I must stress that there be no delay in getting an infant screened for SCID or for any of the other diseases in the Tennessee screening panel. We therefore urge that you collect samples within 24 to 48 hours after birth and have them sent to the state laboratory within the same day of collection, if at all possible.
Hello, my name is Jeannie Jowers, and I am the Newborn Screening Follow-Up Program Nurse Manager for the state of Tennessee. When the newborn screening nurses receive an abnormal result from the state lab, they will immediately contact the primary care provider listed on the filter card for further recommendations. It is very important that the hospital lists the primary care provider who is going to be seeing the newborn once discharged home. A delay in finding the primary care provider could cause a delay in diagnosis and treatment of the newborn. Once we notify the provider by phone, we also send them a written report with the results, demographic information, recommendations for next steps, and contact number for the tertiary center. It is vital that the primary care provider follow the recommendations as soon as possible. Identifying babies with disease and getting them in for treatment is extremely important. After we identify the babies and notify the primary care provider, we will also notify the tertiary center. Tennessee has a statewide genetic network set up to assist in follow-up, confirmatory testing, diagnosis, and treatment. The follow-up program will monitor the newborn until either the case is closed with a normal test or has been confirmed with disease and is in the care of a specialist.
For the purposes of SCID screening, the state of Tennessee is divided into sections, each of which has an identified genetic center and immunologist to work with the state screening program. When a baby has a newborn screening result concerning for SCID, these specialists will work with the state lab and the primary care doctor to contact the families and get them to a center for confirmatory testing. These studies will include a complete blood count with differential and flow cytometry for T, B, and NK cell numbers. If these are abnormal, further testing will be indicated and the immunologist will arrange this. Not all babies with a positive newborn screen will truly have SCID, so the geneticist and immunologist will work together to determine the proper diagnosis based on confirmatory testing. The definitive treatment for SCID is bone marrow or stem cell transplant, so these children will ultimately need to be referred to a hospital that has expertise in performing transplants in children with primary immunodeficiency. Before transplant, however, these babies will need supportive care to help prevent infections like antibiotics or immunoglobulin replacement. They should be placed in a protective environment that limits the chance of infection while they are awaiting transplant. These babies should not receive live viral vaccines like rotavirus, MMR, or varicella due to the risk of contracting the illness from the vaccine itself. Genetic counselors can help the families understand their risk of having another baby with SCID should they desire more children.
We want to thank all of you for the great work that you do every day to help keep Tennessee's infants healthy. That involves collecting newborn screening samples, doing that correctly, getting them submitted to the lab in a timely manner, and following up on these babies when there's an abnormality. On behalf of the Department of Health, those babies and their families, thank you.